Thank you very much. I'm very glad to be here. As I said already yesterday, it's the second time for me at INASL, and I really enjoyed last year, and I'm enjoying this year as well. So the topic of my presentation is the impact of MASL on the liver transplant waiting list and survival after transplantation. I also remind that this is a session with ILTS, and I thank also the president of ILTS for the invitation as well. So this is my agenda. I will talk about SLD as indication for liver transplantation, what is the natural history of SLD in the waiting list for liver transplantation, the survival after liver transplantation, and some idea that we had recently. Regarding the epidemiology of liver transplantation, we all know that it's changed a lot during the last years since the advent of the new DAA, the treatment for hepatitis C. So as we can see, these are data from both sides of the Atlantic, on the United States side and on the European side. And this was until 2015 on the UNOS one, and the LTR was until 2017, already showing that the important decreasing of indication for hepatitis C and the increasing number of patients transplanted for metabolic liver disease and alcoholic liver disease. Data that have been confirmed by a recent paper that is in press in hepatology from colleagues from the University of Philadelphia, in which it's confirmed that the biggest and the most indication in the United States regarding the listing volume and also the transplant volume is alcoholic liver disease, and as a second indication, the metabolic liver disease. What about in Italy? This is a paper that is in press in JF Reports that has been in collaboration with the Italian National Transplant Center. So we took all the patients transplanted in Italy between 2012 and 2022, 10 years time, and there were just a few more than 6,000, and we divided them in patients with non-MET disease, that means non-metabolic disease, and patients with MASLD. And within MASL, we divided between poor MASL, or patient with only metabolic liver disease, and mixed MASL. In the mixed MASL, we can find patients that had both hepatitis C or hepatitis B or alcoholic liver disease and metabolic disease. So in this group of patients, the ALD one, the one on the down here are what are called in the new nomenclature the MET-ALD. So we confirm the epidemiology in the whole population, and then in the non-hepatocellular carcinoma and in the hepatocellular carcinoma, confirming that the indication has metabolic liver disease and alcoholic liver disease are becoming the most frequent in our data. And then we considered only the metabolic liver disease patients, again, different group, the mixed one, the MASL, and the non-MET, and we divided for HCC and non-HCC. And as we can see, when we divide, the ones that are the mixed one are the one that seems to be the most, that will be, at the moment that are, and there will be in trajectories, because thanks to a regression linear model, we could get the trajectories of this patient until 2030. So this is all confirming that these patients in the future, metabolic liver disease, including also the alcoholic liver disease, will be again the most important indication for liver transplantation. What about the natural history of SLD in patients waiting for liver transplantation? These are data published a few years ago, in which they checked for the incidence of waitlist mortality, the incidence of transplant, and the incidence of recovery in different etiologies. So regarding the incidence of waitlist mortality, PBC seems to be the ones that they have the highest rate of mortality, while regarding the incidence of transplant and the recovery, alcoholic liver disease seems to be the ones that will get transplanted more compared to the other disease also that will get the incidence of recovery. But looking also at 90-day mortality and 1-year mortality, 90-day transplant and 90-day recovery and 1-year recovery, they compare the authors to all the alcoholic liver disease. And what they found is that both 90-day mortality and 1-year mortality, patients with metabolic liver disease and PBC, they had the highest mortalities. Why this was not present in the 90-day transplant? So the patients that were supposed to be more transplanted in this group of disease are the ones by hepatitis C, and regarding the recovery, there wasn't a huge difference. Apart that at 1 year, the recovery one was less frequent in patients with metabolic liver disease compared to the other one. This is a quite interesting paper published by the group of Singapore. I think Dr. Lim was here yesterday at the meeting, and they showed this very elegant paper in Journal of Hepatology last year, in which they used a huge number of patients because they evaluated almost 30,000 patients. They made some comparison between patients with the metabolic liver disease. At that time it was still NASH, so they compared the NASH with non-NASH patients. What they found that patients with the NASH cirrhosis were listed a lower model for end-stage liver disease, but the overall transplantation probability in the waiting list of the metabolic liver disease is less at 3 months and at 12 months. Then they moved in the mortality in the waiting list, and what they find that the wait list mortality was significantly higher in patients with metabolic liver disease, both at 3 months and 12 months. And this was even higher when the MELD was higher than 30. But of course, why this patient die more than the other indication in the waiting list? This is another published paper in the 2023, and what they found actually that the main risk factors is the MELD, so the highest MELD is the highest possibility of mortality, and also some cardiovascular risk. So it seems that cardiovascular risk influence also the mortalities in this group of patients. However, we did also the competing risk of death and dropout in our paper. And of course, using also a multivariate model considering age, gender, blood group, study period, center volume, and MELD sodium. And what we found actually that the risk of dropout was higher in non-HCC patients. So it seems to be that the presence of the HCC doesn't make any difference in the dropout of this patient, as we can see from this slide. But we were expecting, of course, as it was showed in the previous paper regarding the non-liver complication, but in our data, we only found that the primary driver of this waiting list, highest waiting list mortality was the liver disease, more than other disease as complication. This because we think that, for example, cardiovascular disease, if you do a right evaluation before the transplant, so with all the technologies that we have now at the moment, maybe they won't have any cardiovascular complication during the waiting list and after the transplantation. Regarding the survival of after liver transplantation, this is the paper by ILTR published a few years ago, in which they checked for all the different etiologies, showing some differences in the long-term survival. But we also, there is this other paper where these authors considered only patients with HCC, and they checked for tumor-free survival and overall survival, comparing patients with MASLD and patients without MASLD. And both of them, both of the tumor-free survival and overall survival was better in patients without steatotic liver disease compared with those with steatotic liver disease. And this is a really nice meta-analysis led by the group of Singapore again, where they analyzed all the numbers of patients transplanted for NASH until a few years ago. So the number of patients considered was very high, confirming that 20% at the moment of the meta-analysis of all the indication was due to metabolic liver disease. So they found that there was no difference in graft survival between patients transplanted for NASH and patients transplanted for other disease. Even in the overall survival, when they compared with a single disease, they found that the only difference was with patients transplanted with hepatitis C. And then they checked also the post-liver transplantation mortality, and the MELD score was associated with worse survival in NASH patients compared to non-NASH etiologies, having an expected mortality rate with metabolic liver disease at 1 year, 5 years, and 10 years, as is shown in the slide. Then they checked also for the risk factors for the mortality after transplantation, and the only one that seems to be have some influence in the NASH group was the presence of sepsis. But this is difficult to understand at the moment why. They did also a meta-regression, as you can see on the left side, a bubble plot, and then they checked also the meta-regression for overall survival, and in both type of statistic, they found the MELD, so the type of the functionality of the liver before the transplantation as the only risk factor for the overall survival after the transplantation. Regarding our paper, we also check, of course, the post-transplant survival, and we only found that in the group with transplanted for hepatocellular carcinoma, there was some statistical difference in patients with a mixed disease, while there was not any difference in the whole population and in patients transplanted for non-hepatocellular carcinoma. Again, we checked which could be the possibility for giving this difference in the in the mixed patients transplanted, and this was again the only statistical significance that we found in the overall survival in the long term of patients, so the mixed patients. The interesting thing that we found, we checked with the Monte Carlo statistic, the gain in life expectancy months, so the 5-year transplant benefit, because we also heard during this day that we are checking now the benefit to do the transplant versus the futility of the transplant. And we found that there is the transplant benefit, but the transplant benefit that we found was only in patients without any HCC. So this means that the patient with metabolic liver disease that goes to transplant, they get less transplanted because they have highest mortality, and they also, if they are transplanted, they will have more benefit compared to those that do not have any metabolic liver disease. So what's the hypothesis could be? This is just the implication of what I just said. So there is the risk of death without transplant, without HCC, higher than other candidates. The transplant survival benefit for this patient is more significant. This incremental effect of muscle on 5-year transplant survival benefit persists across different MELD sodium values, even if it appears more pronounced for low MELD sodium values. So there might be some implication for future allocation policies. In conclusion, the transition in nomenclature from NASL to MASLD and now to MASLD, in my opinion, reflects our ongoing commitment to improving disease awareness, reducing stigma, and enhancing liver disease diagnosis. MASLD, if we now consider not only the metabolic as we used to do, but considering the MET-ALD that were the MASLD mixed with alcohol in this paper, and the alcoholic liver disease pure, it is already, but it grows. It is growing as a most indication for liver transplantation, and it significantly influenced the waiting list survival of patients without HCC, increasing their risk of death during their time on the list. The survival benefit of transplant in patients with MASLD without HCC surpasses that of other candidates, regardless of the degree of liver dysfunction. And finally, for example, in Italy we do get a lot of attention on transplant benefit in our casuistics. So we're already implementing the transplant benefit principle of organ location. Our study may suggest an increase in transplant priority for muscle patients without HCC. This is because we are always working on changing the rules for the priority, as we did for non-med patients, for PBC. So in the future, in those patients that we think they are enough fit to have a transplantation, but having a metabolic liver disease, this could be a possibility, but it is something that we can discuss. So I would like to thank again the organizer, and I would like to remind you that in a few months, in next year, we will have the Steatotic Liver Disease Summit in Portugal, and then the Liver Cancer Summit in France in February. And of course, we look forward to seeing and welcoming all of you in Amsterdam next year for the INASL Annual Congress. Thank you for your attention.
Thank you very much, Dr. Russo. An excellent presentation. Your last statement, actually, which you said that the metabolic liver disease, probably those who are non-HCC should even get an organ priority. Is that what you were telling? That's a very, is that such a strong evidence-based thing which we can take at this stage? Can we say that somebody with metabolic dysfunction, liver disease on wait list should be given priority? That's what I...
This is exactly what I was saying, that maybe because we just seen that they will die more in the waiting list, and they have a better benefit after the transplant. So this is an idea that we are considering, and at the moment we are rewriting all the rules in Italy about the extra MELD position, and we are, of course, we are not using that much anymore, the MELD, but we are using a different score that is called ISO score. So we might consider also to give some priority in these patients. Of course, those patients that already they do not have any cardiovascular complication or any further risk factors for maybe not arriving at the transplant.